Hello, I'm Alan Weil, Editor-in-Chief of Health Affairs. Thank you for joining us for today's Policy Spotlight with Carrie Colla. Policy Spotlight is a series of virtual events that Health Affairs holds featuring in-depth conversations with influential health policy experts. We've had CMS Administrator Chiquita Brooks-LaSure, FDA Commissioner Bob Califf, White House COVID-19 Response Coordinator Ashish Jha, and many others. All of our Policy Spotlights are recorded and can be viewed at any time on our website. I'm so happy today to be joined by Dr. Carrie Colla, who is in her penultimate day as Director of Health Analysis at the Congressional Budget Office. Tomorrow she will depart, and Chapin White will be assuming that role. So we're happy to catch you before you sneak out the door. Dr. Colla has been directing that unit since August of 2021. She manages a team in the Health Insurance Modeling Unit, Health Policy Studies Group, focused on prescription drugs, the Health Market Studies team, which focuses on provider markets and pricing. Her team analyzes programs and policies like Medicare and Medicaid and subsidies in the health insurance marketplace. We just last month published CBO's 10-year projections on health insurance coverage. Before coming to CBO, Dr. Colla was a professor at the Dartmouth Geisel School of Medicine, which position she assumed in 2010. She's had a number of terrific and important roles. She was a Robert Wood Johnson Foundation Health Policy Fellow in 2017 and 2018, with a placement in the House of Representatives and at CMMI. She's been an emerging leader in health and medicine at the National Academy of Medicine. Her undergraduate degree is from Dartmouth College, her master's and PhD in economics and health policy from the University of California, Berkeley, my alma mater as well. It's great to have a golden bear on the program with me. Dr. Colla, it's a real honor to be able to spend some time with you. For our audience members, if you are watching live, you do have the opportunity to ask questions. You can put them in the Q&A box. There's a little button at the bottom of your screen. I'll do my best to weave those into the conversation. It helps if they are of general interest and if you can keep them on the shorter side so that I can read them at the same time as I'm trying to have this conversation. Dr. Colla, it's so nice to get some insight from you. And what I want to do as we sort of think about the arc of the conversation is just a little bit about sort of the institutional role of CBO and how you've approached that and what you've learned doing it. And then we'll get into some of the thorny substantive topics that you've had to address during your tenure. And I close out with a little bit more about your career and how this fits within your broader goals. But just to start, I think most of us on the outside think of CBO as the scorekeeper. Legislation is dropped and CBO tells us how much it's going to cost or how much revenue it's going to generate. But there's a lot more to it than that. Can you just give us a little bit of a thumbnail of the various roles that CBO plays in, particularly your division, of course?
Yeah, thanks so much for having me. I'm happy to be here with you and to have a chance to talk a little bit about CBO. It's really been a joy working there. So we do interact with the Congress in many different ways. You mentioned cost estimates, which is probably what we're known best for, but there are a number of other things that have to happen in order for us to create cost estimates. So a lot of things that are happening behind the scenes, and then a number of other ways we work with the Congress as well. So a lot of our workload goes into creating a baseline, which is what we estimate cost estimates from. So we create economic and demographic projections, which in our group includes creating health insurance coverage projections. And then all cost estimates are done from that 10-year baseline of what we expect to happen going forward. Other ways we work with the Congress include writing reports. So members of Congress and members of committees of jurisdiction and health will ask us to write reports on specific topics. Sometimes they have a policy goal in mind and they want us to help them identify what policy options would be to work toward that policy goal. For example, we put out a report last year about commercial prices and policies to reduce commercial prices and what the economic and budgetary effects of those types of policies might be. We also create and refine and update models that we use to create cost estimates. And then we both consume and produce research to fill knowledge gaps. In our division, the Health Analysis Division, we're thinking about where Congress might go in the future. So we're thinking about what we might need to estimate the effects of future policies, and what research we need now and what infrastructure we need now to be able to do that.
So it's really helpful to, go ahead.
I'm going to add also about technical assistance.
Please.
So we probably, what the public reads about is mostly our public cost estimates, but we also work on an informal confidential basis with congressional staff to give them a sense for what the effects of legislation might look like. And so some of that is technical assistance around the language and thinking about what implementation of specific language would look like. And so there tends to be like a lot of back and forth as members of Congress are creating legislation on what the dials might be about how much different policies will cost.
Well, you perfectly foreshadowed what was going to be my next question. So what you've described is basically you need to be able to turn quickly to address issues. And so there's a lot of infrastructure that you have to keep up on baseline and models so that when things come over the transom, you aren't starting from scratch, obviously. But I'm really interested in that last point you made. That was the question I was about to ask. So if I'm a member of Congress and I'm thinking I want to do something, or I want to, I'm working on a policy here or there, somehow I have to get a sense at the beginning of the process of what the general scope or scale of the impacts might be. And so you're saying there is an informal confidential process where that can occur, and they can then use that as input as they're building and refining the legislative language?
Yes, exactly. It usually ends up being with committees of jurisdiction as they begin to move into the markup phase, just given our bandwidth resources. But as they're moving into the markup phase within the committees, we provide them with a lot of information about the potential budgetary and economic effects of the legislation they're considering.
So it won't surprise you, since you're talking to Health Affairs, that some of my early questions really have to do with evidence. And I have a lot of them, but I'll try to get through a few of them. So first of all, I'm just curious about, of course, we take very seriously peer review and being part of the published literature. There's a lot of great work out there, not as great as ours, but there's great work in the gray literature that's self-published. I wonder what credibility you give to that. You have a panel of health advisors who presumably offer advice that isn't sort of traditional published kinds of advice. So if you could just tell me a little bit about how you think about evidence quality, evidence sources.
Yeah, I would say we collect information from every available source. Like if you want to talk to CBO about a topic, if you want to give us sources of information, we're very much engaged in the stakeholder community, and I would say vacuum up different sources of information and then process it on the inside. And so we definitely take into account the quality of the methods that go into different types of research. We evaluate where it's coming from. So I would say we collect information from tons of different sources and then evaluate it and choose where to put more or less emphasis based on the quality of the research in particular. And we can take into account where it's published in that context as well.
And someone from the audience asked, I think, a terrific question. Are there areas of health policy or health services research where the evidence base is maybe thinner than you would like, and it would be helpful to you in your job and your work if some people would focus on an area that isn't as well attended to as it maybe ought to be?
Sometimes we actually put out information on our website about areas where we could use more research. And so I think that there's a couple right now that we would choose to focus on. And one is particularly on costs on the provider side. So how and when do providers change their cost structure, and how do they respond to different stimuli in the market, whether it's prices or other policy changes, how providers change their supply, and like both the number of services that they want to provide and what they cost to provide those services would be one example.
That's great, because we spend a lot of time looking at prices. And we have a whole transparency initiative around prices, but we don't, and there's of course their cost reports and the like, but not quite
information on provider costs as many know.
Yeah, that's great. That's great. One of the transitions we've been navigating at Health Affairs is the massive increase in attention to social determinants. So if we're trying to figure out the, if you're trying to figure out, we're more trying to publish literature. But if someone is coming in with an initiative, maybe on SNAP, the supplemental nutritional program, and they want to say, well, but we know that healthy food helps people be healthier and maybe reduces health costs. We think it's a preventive measure. How have you navigated the sort of, if you will, what I would view as sort of the expanded horizon of what is relevant to health policymakers?
Well, I would say we consider those policies in the same way we would consider a medical policy. And we have thought a lot about food and medicine, in particular in the last few years. And luckily, we also have economists at CBO across the spectrum, right, who are experts in all of these different areas. And we work cross-divisionally with experts in other areas so that we can think about the intersection of health with other areas of policy. And so I would say we think about social policy in the same way we think about health policy, where we would evaluate the existing evidence. And sometimes in this social policy, it's a younger literature and there isn't as good evidence. And so then we would talk to researchers about what in particular we would need to see. Sometimes we've also experienced that particularly for preventative measures, these interventions will be put in place for a very targeted set of patients or populations. And one of the things we need to consider is the impact on the federal budget overall. And so what that means is that who we think will use service might not be the same as a targeted population in a particular research intervention. And so thinking about the targeted population, how it might spread, what potential other consequences that are unanticipated might be. And then we also think about the population broadly and the other services they might use. So this is often a case, like we get asked a lot of questions about prevention and why prevention doesn't necessarily save federal dollars. So you also need to think about, are these services being paid for off the federal budget? And now some of it will be moved onto the federal budget where for what CBO is considering, those would be additional costs. So the bottom line is we think about it in the same way we think about any policy, and we have experts in all of these different areas. That's a fortunate thing about the Congressional Budget Office.
Yeah, that's great. Back a couple of decades ago, I was running a project at the Urban Institute that looked at broader social policy and health policy. And it is striking. We have a very robust health services research field. I know there's more we could do, but relative to a lot of the other social services, there's a lot more research funding, and we have things like electronic health records that don't exist in many other areas. Bottom line being that often research availability is much more limited in some of those domains, and it's a challenge.
Yeah, I should mention that we're not just a consumer of research too. We have 35 economists in the health analysis division, and many other economists across the agency who are doing their own research as well in those areas where we think there are gaps. We will seek to fill them on our own, given if we have the data and the resources we need to do so.
So I appreciate you mentioning economists. So we think, again, at CBO, we think a lot about cost estimates. But behind those, as you mentioned, are models that have behavioral elements to them. There are also other dimensions of public policy that policymakers care a lot about, other than just the cost, even as they do care about the cost. Can you talk to me a little bit about things like equity? Where does the increased focus on achieving a more equitable health system and a more equitable society, where does that fit? How do you look at that dimension as you're also trying to generate broader cost estimates?
There's been increasing demand from members of Congress for us to be able to look at distributional effects of different types of policies. And so CBO has really expanded its capacity to do analyses by income, by race and ethnicity, and other characteristics over the last, I would say, 3 to 5 years in particular. So in the Health Affairs article this month, we published our coverage estimates by race and ethnicity. We put out a report about the distribution of income and federal benefits each year. And we recently put out another working paper about the distributional effects of different types of policies. So I would say we're working hard to increase our capacity to be responsive to members of Congress on that dimension.
And, questions about how to approach prevention have been around as long as I can remember. Where is the expertise on sort of the health outcome side of this? Because presumably the argument around prevention is, it's more than an economic argument. It's also an argument that people's health status will improve, and with better health status, they'll have less need for health services. So I guess what I'm trying to get at is the interplay between the economic discipline and the more clinical disciplines.
Yes, thank you. I mean, we try to always give complete information and as much information as we can. And so while by statute we're required to put out cost estimates, we try to provide additional information whenever possible. And that could be about innovation, it could be about health outcomes. And we're always pretty careful to say that, like, even if someone costs more because they're living longer and spending more on Medicare and Social Security, it doesn't mean you shouldn't do a policy. There are other outcomes to consider, but it is one of the things that we take into account too with increased longevity. So we usually make tables for cost estimates that have the dollars, and often they have footnotes about other potential effects. And when we have more time and bandwidth, we write up cost estimates that would take all of those, like have paragraphs about all of those types of effects as well. So I would say whenever we have good information and bandwidth, like just in terms of the number of demands from Congress, we would always provide as complete of information as possible to do with effects other than just the cost.
Yeah, and you mentioned innovation, and I'm always, again, I think there's a lot of wishful thinking in healthcare where people will say, we've got this great new idea and it's going to save a ton of money. And then some enterprising member of Congress will say, I'm going to write a bill that will promote that. And CBO will come back and say, sorry, doesn't save money. And reality is tough, but I am curious about whether there are innovations out there that you think are really cost lowering that people should be focused on, or how you just think about the uncertainty and is the bias or is the assumption that you expect zero change and someone has to sort of show you why it should either be greater than zero or less than zero, or how do you think about that thorny set of issues?
Two things a little bit. So on the first question around prevention, yes, there are many health policies that, especially in the prevention area, like you mentioned, that have been proposed that could potentially be cost saving. And so the first thing I want to say is that we use a 10-year budget window. And so in the complete information sense I just mentioned, we would give potential effects if we had good evidence beyond the 10-year budget window. And then, but some of the things that that I mentioned earlier, you have to take into account as well. And so that's like, who is going to be using the service, whether it's a drug or a procedure, et cetera. What are other types of services that might go along with that service? Like say since we're talking about prevention, like a screening tool, it may be that there are a bunch of false positives that require follow-up care that we would need to take into account as well. So figuring out who it's going to be targeted to, what are other services that might go along with it? Would there be potential longevity effects that would come into account? How do the new procedure and other types of services offset each other? So when we estimate either increases or decreases in prescription drugs, we think about how that might affect medical care. So I'm saying that there are a lot of moving pieces, but I think many of them in the prevention case point to increased expenses. And like I mentioned, it doesn't necessarily mean they shouldn't be done. It's just a cost estimate, and it's one piece of information among many. But I think that people are often disappointed. People say CBO is the skunk in the garden party because people have these great ideas, and sometimes the truth of what it will cost can be difficult. And so then you also mentioned about uncertainty, and uncertainty is very important. And there's, in all of our reports, there's usually a section that details the sources of uncertainty in our estimates. And some of them are obvious, but many of them may not be obvious to the readers. And so we're careful to lay them out. And what we're always giving is the center of the distribution of potential effects. And so it could be zero if the distribution of potential effects we consider is centered around zero, but not necessarily. And so anytime you're trying to project, right, there's a potential distribution of effects depending on different factors, and we're always trying to project the middle of that distribution. So it's not necessarily that it would be zero in the case of uncertainty, but you would just take into account the best evidence you have. And then one of the most interesting parts about CBO2 is getting together to think about what those effects might be with like a large number of different disciplines and different opinions in the room to opine on it.
I have a bunch more sort of process kinds of questions. How do you approach things? But I have a growing list of questions coming in from the audience about more specific topics. And I think it would be good to get some insight. Now, at some level, you may just refer people to reports and say, well, you want the answer, go read this, and that's just fine. But let's take a very current issue, which is the end of the public health emergency and the unwinding of continuous coverage in Medicaid. Maybe if you could just sort of walk us through. I mean, we were in a public health emergency, the policy was frozen, then you start getting a question of when will it unwind? And it was delinked from the end of the emergency. You get a question of how will it be unwound, over what period of time, what expectations, what resources. And I don't know if you said that the conversations with members are confidential, but I don't know if it's the content of the conversations or the existence of the conversations that are confidential. But just like, if you could just give us like a feel, take this as a case study. This is a policy we knew was coming along. At some point, the emergency was going to end. Where do you start? Where do you enter? Where do you land?
Okay, well, on the confidential note, I won't talk about either the existence of conversations or the content of those conversations, but we put out really good information about this in the health affairs paper on our projections of the unwinding. So we're projecting an 18-month unwinding that started April 1st because the Medicaid, so sorry, let me just be really specific. There's many parts of the public health emergency, but you're asking particularly about the continuous eligibility in Medicaid and the unwinding of the continuous eligibility provisions, which means that states across the country are doing redeterminations to see if people's income and need and asset levels meet the thresholds within their state. And so this is something that Medicaid directors across the country are focused on. And some states started right away. Some states, it's over a period of time, the legislation that they have to complete the unwinding or the redetermination process. And so their Kaiser Health News or Kaiser Family Foundation is putting out estimates regularly about the unwinding. CBO also has projections out in the Health Affairs article about the Medicaid unwinding and further tables on our website as well. So that information is all public and available for people to consume.
So help me. Yes, I'm sorry I was a little ambiguous in my question. I wanted to focus on something small enough that we could sort of get our arms around it. I guess what I was hoping is you could also give a little bit of the background process. So those are the assumptions about the unwinding and the approaches states will take, but you have to estimate how many people will lose. You have to estimate how many people will get other sources of coverage. You have to make some assumptions about how states are going to, how aggressively are going to try to connect people to new options. So I was just break open that box a little bit, and in you're sort of faced with this big policy, because I'm going to ask you to do the same thing on drug negotiation. Sort of the public sees this headline that says end of Medicaid continuous coverage. Help us understand how you break that into the component parts to figure out what the effects will be. That's really more what my question.
Got it. Process, yes. So let me start with the Medicaid unwinding. So this is with little precedent, right? This type of big redetermination process. So one of the most important things we did potentially was to talk to state Medicaid directors and to get a sense for what is happening on the state level through discussions with like on the ground states about how this is being done and what their expectations are. And so we're collecting that information from many different types of states, like a representative number, and putting that into our coverage projections. And so just to back up a little bit further, we have what we call a health insurance simulation model that takes into account actual data, survey data, and lots of other sources of information to project what people's coverage will be at different points in time. And so this is a economic model that looks at the decisions of people in certain circumstances, given their characteristics, and sees what type of coverage they'll end up with. And so using that model, as well as other both assumptions from information collected and actual information as it comes in, we have made these projections. And there are more details about the health insurance simulation model and others. But I would say that one of the biggest pieces of information we use at this point in time, given that this is somewhat unprecedented, this unwinding, would be collecting information from states.
That's really helpful. So let's take a very different example, which is negotiation of drug prices by Medicare. Again, an area where the politics are fierce, the beliefs and views of people about whether and how much money this will save are very strongly held. And you're sort of sitting there as the arbiter and reaching conclusions about pricing, but also about future innovation and the like. So again, if you could do a similar exercise, this idea has been floated for a long time. How do you start thinking about it? How do you start thinking about what elements of the provisions are relevant to what the estimates are? How do you help guide legislators in thinking about how to make sense of this issue?
And this is one where we had a number of years of notice. So
Yes.
has been working on understanding the effects of a potential negotiation model since about 2017, and working with members of congressional staff on what that would look like. So maybe I can start first by just talking a little bit more about the policy and what was implemented. So maybe I'll talk about Medicare Part D first, because those are the provisions that go into effect first, and leave Part B, which is slightly different, out of it. So most of your listeners probably know that in Medicare Part D today, prices are determined through negotiations between manufacturers and Part D plans or their pharmacy benefit managers. And so the goal is that the secretary is required to select 10 Part D drugs this year. They'll select them for negotiation, and those prices would go into effect in 2026. And so the provisions for which drugs can be selected are that they have to be among the top 50 selling drugs, like in terms of revenues. They can't have a generic or biosimilar competitor, and they must have been on the market for 7 years. So, and those were all things that were changing in the news, as well as like different forms of the bill. And so we, Evan Hernstead and Chris Adams at CBO wrote a working paper about like a Nash bargaining model for drugs, and that's part of our transparency initiative, is to put these types of methods out on the web. And so we were thinking both about like what would be the leverage, and then what would be the set of drugs that would be subject to this type of negotiation. So using both economic methods on the one hand to think about the bargaining model, and then data to say what the drugs might be, or what cohorts of drugs might look like that would be negotiated. And so like a couple of more pieces of information about what we thought that might look like. So in the end, we estimated that price negotiation would lower average drug prices in Medicare and would reduce the budget deficit by $20 billion in 2031, which at the time was the end of the 10-year budget window. And part of that was that we knew that, or we estimated that the negotiated drugs would account for less than 1/5 of total spending in Medicare. So taking that into account, and then using the bargaining model to get a sense for what the prices might end up to be. So also in the legislation, there are provisions around what the maximum price can be that the secretary has to take into account. And those have to do with basically previous prices in the Medicare and other markets. And so CBO determined that the price would likely be below those ceiling prices and save about 8% overall across average drug prices. And so taking, the total spending we expected and that price change we expected into account got us to that number over the 10-year budget window, given the implementation timeline. And then the next thing I'll say is that we will be monitoring the implementation of negotiation, and already are, as the administration is coming out with different types of regulations related to negotiation, and continuing to learn and update what we think will happen based on what's happening on the ground.
And is there something that's a corollary to what you described around Medicaid with checking in with states? Do you talk to the PBMs? Do you talk to the manufacturers? I'm sure they would love to spin it one way or another, so you have to take that into account. But how much of that kind of communication occurs as well?
Tons. So anytime we're starting on a new topic, and basically anytime someone reaches out to us, we just collect information and take it into account. And I think it's easier to work with us when we're actively working on a topic. Otherwise, we might say, like, send us materials and we'll read them. But we really take into account information from across the spectrum, and really heavily consider different voices and pieces of information. And I've always been astounded since I've been at CBO by the amount of information that our analysts are able to process. It's a lot.
One of our listeners asked about what you're working on in mental health policy, and I realize that's a very broad question, but I thought it was a good one, so sharing it with you.
Yeah, it's a very active area for members of Congress, and we are starting some new work in this area. Some things that are we put out a work in progress every quarter, and so those are the things that we can share publicly. So we just put out the most recent work in this area really has to do with substance use as an area of behavioral health. And so we put out a report last year that was about the federal responses to the opioid crisis, and discussed the effects of 3 federal laws that Congress passed between 2016 and 2019 in response to the opioid crisis, and what the effects have been. And we're working on a second report in that area that's about federal options to cope with the opioid crisis, and what are additional policies. And one of the reasons that's important right now is that the Support Act from 2018 and Cures Act and other of these earlier laws have provisions that are beginning to expire and will continue to expire for the next two years. And so Congress is considering what might happen in response to those provisions expiring. One further note that I don't want to get into too much of the details of, because it's a complicated area of policies, that we just recently, about 2 months ago or 1 month ago, put out a report on eliminating or reducing the IMD exclusion. So IMD is institutions for mental diseases, and Medicaid doesn't pay for services and institutes for mental diseases for residential facilities that have more than 16 beds. And so in response to a request from Congress, we looked at different options to pay for those services, and what the federal and budgetary and economic effects might be.
Great, thank you. That's really helpful. Mm-hmm. I'm going to return to a few more process, and then we'll maybe bounce around. But a member of the audience asked a question that's very similar to one that I was planning on asking, which has to do with sort of your retrospective review. So you do lots of projections, and then the world happens. And I'm curious how much attention you pay to whether or not the projections were accurate, what kind of teardowns you do of the models or revisions. And of course, lots of things happen that could make the projections inaccurate that are not a sign of weaknesses in the projections. They're just the complicated world we live in. But just love to hear about how much backwards looking you do as well as forward looking.
Well, probably the most important thing to say is that we put out a report every year about the accuracy of our projections. So that's an annual report. I would say in healthcare, it can be particularly difficult to disentangle what the effects of different policies are after the fact, like how accurate our cost estimates were, because there's always many things happening at once in health policy. But we do constantly look back and try to disentangle. One of the things we do is we look at changes due to legislation versus technical changes. We update most of our models every year. So we go through a process with our health insurance simulation model where we have technical updates on a regular cycle. And so we're always trying to improve the accuracy of our projections. And while also updating for things that have happened in the meantime, whether it's regulation or new legislation, et cetera.
So this may be a slightly unfair question, in which case I apologize, but I'm going to ask it anyway. When I think about the great paper you all did on coverage projections, my shorthand is not that different from how I react to the National Health Expenditure estimates, which we also publish every year from the actuary, which is there are huge disruptive effects associated with COVID. And the paper talks about, we've just been talking about the Medicaid continuous coverage provisions. There are the increased subsidies for marketplace plans, and those come to an end. And then when you look a few years out, the trend lines look pretty much indistinguishable from what the trend lines were before COVID. I mean that metaphorically. I'm not doing a statistical analysis here. In both of these processes, and you're of course not responsible for the actuaries, it looks as if, as dramatic as the consequences of the pandemic were in so many different dimensions, that from a modeling perspective, from a forecasting perspective, there aren't sort of lasting structural effects that are visible to the untrained eye like mine in terms of broad trends that we care about, whether it's spending or coverage. So first of all, I wonder if you would agree with that. And then, well, maybe I should ask that first, because depending on whether or not you agree, it might affect what my next question.
Yeah, I mean, the thing that I'll say first is that we have better information about what's happening in the near term, right? Like we know that certain provisions that came out of pandemic legislation are set to expire, and so we can kind of react to those. And we do talk to actuaries about what projections for premiums, for example, will look like, and they also have better information about the short term. So I think that a big area of unknown, so what happens with some of these temporary provisions, we don't know. And one of them is telehealth. And so one of the ways healthcare has fundamentally changed in response to the pandemic is telehealth. And we don't know what all of the provisions will be going forward, particularly in Medicare is what I'm talking about. And so I think that that's a big unknown, but we're estimating current law. So we're estimating things to expire as they're projected to expire at this time. And so if we have like a fundamental permanent change in telehealth, that could be one thing that is a structural change that continues on out of the pandemic.
So I completely appreciate that answer. I think I was thinking of something slightly different, and we don't have to belabor this. I totally get that your charge is to look at current law, and if the provision expires in current law, then you have to assume it's going to expire even, and we have many examples of situations where everyone knows that provisions are not going to actually expire, but you're bound to look at them as if they will. So I understand that. I was thinking more about not temporary legislative changes that expire, but more like structural changes in the health system, whether, something creates a huge level of consolidation that might give us different price points, or something shifts employers' offers of coverage in a way that would fundamentally change the number of people who would have health insurance through their jobs. I'm not saying those, I'm just using those examples. I'm not seeing anything that suggests your models are looking at what's happened in the last few years as causing fundamental structural change in sort of the underlying health system. That was more what I was trying to get at.
Yeah, I'm just thinking about it, because if we thought that there was a structural change like that and there was evidence to support it, we would factor in those, I would call some of those behavioral differences in behavioral responses, like patient responses, provider responses, family responses in terms of household insurance or employer responses. And there hasn't been evidence of most of the things that you mentioned that we would take into account. So maybe it just remains to be seen whether there will be some of those broader structural changes, and then we would take them into account. Some of the ones you mentioned, there is some evidence for, and I would say like every year we would incorporate more and more of that as it comes out.
There's a question from the audience that I'm not even sure I can fully interpret, but I think it's a great place to have a conversation. The person asks, how are economic theory conflicts among the economists addressed or resolved? So, you know, I'm just going to let the question speak for itself and see where it takes you.
My answer is short, it's discussion. Like in a room together, whether it's a virtual room or around the table in the conference room. And we have them for sure. And it's one of the most fun parts of the job.
Can you give me an example of a theoretical question that you've had to grapple with?
Yeah, not today. I'm trying to think of one that would be that we've published on. So nothing off the top of my head.
That's okay. That's fine. I think I think your answer is very helpful and very interesting. So yeah. Very good. So let's turn, as we're coming a little bit towards the end, I want to turn a little bit more to some structural, and then close with where I always do, which is to talk to get a little insight from you about your own career. But you've got a real team there, and you've got some real talent. What are you looking for when you're hiring? What skills does someone need to be successful at CBO?
Thank you for asking that, because we're always looking for good people. I would say training in economics is like the easy one for the most part in our health analysis division. We also hire assistant analysts who are out super bright students out of undergrad who often go on to grad school, but not always. Our budget analysts usually have master's degrees, but I think so those are like the qualifications, but I would say devotion to public service would be part of it. An interest in getting the answer right, and like an interest in helping knowledge and research inform policy in a way that is not tied to partisan or other types of beliefs, and people who are technically very well trained and interested in detail-oriented work. The other thing I'll say on top of that is that we tend to communicate our results in ways that are for educated but not expert audiences. And so the way we try to write, the way we try to speak is very much not a technical economic language. We write working papers as well, which are more in that field, and we publish in the academic literature, but we also need to be able to communicate research findings to a general audience and our analyses to a general audience. So I feel very lucky to have been part of the team at CBO. The people are wonderful. Like, so maybe I should also add like nice to that list. Collegial, and also very much willing to teach each other about different topics.
That's great. That's really helpful. You know, you referenced, of course, ideology, but you do operate in a tremendously politicized environment. I wonder if you could say a little bit about how you navigate it, what resources are available to help you navigate that.
Well, I mean, part of it is what we talked about before about evidence. You know, we really rely on evidence. And so if the evidence is there, that's what we're talking about. We're not talking about beliefs or and any of that. And so, I mean, our nonpartisan objective status is really what gives us our voice in Washington, as opposed to many of the other constituencies. And so part of what I mentioned too about there being many different people in the room with different views, like, you know, disagreeing and examining different types of bias in the discussion. And so it's not something I think most people at CBO find difficult, which I maybe would surprise the public. But I mean, if you're there, it's not a place that people would be happy if they had strong partisan beliefs. As an employee, you're there as a public servant to help the Congress make decisions based on research and evidence. And so it ends up being quite straightforward at the end of the day.
And you referenced the 10-year planning horizon. How do you feel about that? Does that seem sort of as far as your tolerance for uncertainty stretches, or does it really truncate our ability to understand certain interventions that would have a longer time horizon, or would it just feel like guessing if you went beyond that? Curious how you
Yeah, I'll answer that in two different ways. One, we do have the long-term budget outlook, which is the 30-year projection, and we look at the solvency dates for our Social Security and trust fund and Medicare trust funds on a longer time horizon. And so we are creating projections on that 30-year window. We used to do it on a 75-year window. I think that made a lot of people uncomfortable. 75 years is a very long time. And we fully acknowledge that after that 10-year window, it's a different amount of uncertainty you're dealing with. In terms of your other question about healthcare policies in particular and their effects outside the 10-year window, we would love to be able to give complete information about what happens after the 10-year window, even if it's qualitative information. There's often not in the research long-term effects of different types of policies. So if we have good evidence to say, here's what happens after 10 years, we would be likely to include it in a footnote or in another way in our analyses, but it often doesn't exist good evidence. And so members of Congress have asked us about that. And it's something that we try to do if we have good information, but obviously the amount of uncertainty increases the further out you go.
So when I asked a number of our circle at health fairs to help me come up with questions, they came up with a long list of topics where they're just sort of curious. What do you think about telehealth? What do you think about price transparency? What do you think about mental health? And I guess I want to ask again sort of an institutional question, which is basically the answer, if we've written something on it, you can read it, and if we haven't, we can't really tell you what we think about telehealth? Is that, I mean, I don't mean that I hope you don't take that the wrong way, but that seems to be the environment. Is that the right way to think about it?
Yes, it's true for lots of areas of government, but I think in particular at CBO. So one of the things about CBO and our institutional role is that we don't provide policy recommendations. We give information on different types of policies. And so we can give, we have a document that we put out every year called budget options, and we draw different types of proposals from all over the policy spheres and say what would happen if you put them into place. But we're not saying this policy is the right one to do. We don't make normative judgments about different types of policies. And so I won't tell you what I think of telehealth or mental health or any of those things. I just would be able to tell you what would happen if you put different types of policies into effect. So you're right.
Yeah. And you could tell me that only through a written report that is available to the public, right? Is that?
Yeah, I mean, we try, when we have things to say, we try to put them out. We can't always do that simply because of bandwidth, because sometimes we have to move on to the next thing too quickly. But I will say, like, from a transparency perspective, we try to put out as much information as we can. And if you've ever tried to navigate the CBO website, there is a lot of really great information there. When we've developed a analysis of a certain type of policy, it's usually somewhere on our website.
And we talked earlier about areas where you'd be interested in seeing more research, and you even have something written about that. I'm curious on the data side. We have this proliferation of new data under the transparency provisions. There's been talk for a long time about the greater ability to analyze electronic medical record data as opposed to, paper records, of course. Are there places where you see not just analytic gaps, but data gaps that you think it would be particularly helpful for us to fill in order for you to do the work Congress needs you to do?
Yeah, I would say that I mentioned provider costs earlier. I think that's an area where, I think providers even have trouble with the measurement. But I will add that we have data from lots of different sources within the federal government, and we often buy data sources from outside the federal government, but definitely our access to data from anywhere in the federal government is stronger than from the outside. But I would say that would be the thing that would come to mind first, would be provider costs. And commercial data, commercial insurer data have gotten better in the last few years. I think there are many researchers who would love to have access to better all payer claims databases and that type of information. So I would add that as well.
And you mentioned talking to state folks about the Medicaid unwinding, but I'm curious, there are more and less sophisticated versions of what you all are in a number of states. Not all states have something, but some of them are very skeletal. Is there much cross-fertilization of data, ideas, models, approaches, or are the issues so different and the scale so different that you basically operate in separate spheres?
I guess like a general answer, I would say separate spheres, but we're talking to the states a lot more on the administrative side of what they're doing or what they're finding out from the research. But I haven't heard much about like talking to, well, that's not true. If a state implemented a policy that the federal government was or some member of Congress was thinking about, we would absolutely talk to those researchers on the state level. And we have state level executives on our panel of health advisors as well. So again, I would just say we collect information from as many places as possible, and we will go find them whatever is most relevant to what we're currently analyzing. So there's no structured way that we're reaching out to like specific research shops or budget offices at the state level that I know of, but constantly touching base with the states.
Great.
And so I guess that there are some state budget offices that we have interacted with, and I will add internationally as well, for other countries' budget offices as well we communicate with.
So as we come to a close, I always ask, I always want to get a little bit of the inside the person, and this is a really incredible role you've been able to play. If we hope some of our listeners are earlier career and they're thinking, I'd like to sit in that chair one day, what might you tell them to do if that's the goal that they have?
Well, I think early on I was really a researcher, right? Like, and I still use all of those skills. I'm not doing any of my own research anymore, but I need to be able to understand research really well and understand data. So I spent lots of time like understanding Medicare and Medicaid claims data. I'm not working with those data anymore, but I know what their strengths and limitations are. And so I think in the beginning of your career, establishing those research chops and developing an area of expertise that has a little bit more depth. And now I'm much more broad because I have to understand basically every area of health policy in this role. So getting exposure to lots of different areas, but also establishing solid research skills and depth in that area as well. And then I would also just add, I did the Robert Wood Johnson Health Policy Fellowship, getting an understanding of the way Congress works, the way policy works, and what the different voices are influencing policy is important as well.
Do you see the experience you've had changing your work now as you go back into academia?
Yeah, I expect it will. I'm not exactly sure how yet. I haven't had a lot of time to think about it yet. It's been busy at CBO, but certainly I have learned so much during my time at the Congressional Budget Office, and I'm interested in lots of different topic areas and know more about where we have research gaps. Just yeah, I've been so lucky to have the learning experience I've had at CBO.
So I was going to ask if there are topics you thought you would want to primarily particularly return to, but it sounds like, again, you're busy up until the bell, when the bell rings tomorrow, and maybe you'll have a chance to think about that after the bell. Is that sort of where things are?
Take a little break and reflect. Yeah, but there are definitely some areas too where I would say that there's active congressional interest, and we need more policy ideas and evidence to bear. So there are lots of them. That's
great. Well, Dr. Colla, it's so great to get some insight from you in the role you're playing and the role that CBO plays in our complex political process. It's also just great to get a sense of your own trajectory and how you approach these complex issues and function in as you say, a non-political institution, but in a very political environment where you lead with the evidence, which is exactly what you're charged to do. So thank you for taking some time with me and the audience here to talk about what it's like at CBO and what some of the lessons are that you've learned.
I feel grateful to have a chance to have shared some of what I've learned. And I do just want to say too, we interact with the public. If you go to our website, you can reach our communications team if you have information to give us, or want information on a further topic, or need help finding something on our website, please reach out.
That's great. To our audience, I just want to say thank you for joining us today. We do have some upcoming events I want to make sure you're aware of. On June 13th. We have a journal club focused on the health affairs paper from the June issue on continuous eligibility and coverage policies that expanded children's Medicaid enrollment. On June 20th, we will have a virtual bring your own book networking event at 6 o'clock Eastern to connect with other health professionals and members of the health affairs team. These are Health Affairs Insider events, which is a membership program that we've launched to offer exclusive access to content beyond the journal. And so you will need to be an insider to participate in these. But many of our events are available to all, including ones like this. Please sign up on our website to keep up to date on what's coming, and go to healthaffairs.org for all of those events and to join our mailing list to hear about what's coming up. Again, Carrie, Dr. Colla, thank you so much for the time. To our audience, thank you for joining us. And with that, we are adjourned.
Thanks.
Thank you.